Welcome to Board Pearls. This is episode 3 of the esophageal symptoms and diagnostic workup chapter in the esophageal disorders module. This episode is the dysphasias the standard workup misses, the ones after fundoplication and bariatric surgery, and the ones that reach the esophagus from a disease elsewhere in the body, from scleroderma and Sjogren to amyloid, the nerve and muscle diseases, and radiation injury. The one idea holding this together is that the answer isn't in the scope report, it's in the history. These patients have a surgical or a systemic story that the usual scope-thin manometry workup was never designed to uncover, so if you don't ask the question that surfaces it, you won't find it. That's the whole skill in this episode, knowing which question to ask. Take dysphagia after a fundoplication, where there are a few distinct patterns and each one comes from a different mechanical problem. Remember what the operation is. A Nissen wraps the top of the stomach a full 360 degrees around the lower esophagus, while the partial versions, a Toupet behind at 270 degrees or a door in front at 180, give up a little reflux control to cause less trouble swallowing and less bloating. Now the failure patterns follow from the anatomy. A slipped wrap is when the wrap slides down onto the stomach instead of hugging the lower esophagus, and that produces a combination that seems contradictory until you picture it. Reflux comes back because the wrap is no longer reinforcing the sphincter, and swallowing gets hard because the wrap is now pinching the stomach. A wrap that's simply too tight shows up as trouble swallowing right after the operation because food can't get through, and the fix there is to stretch it with a balloon early, saving revision surgery for when dilation fails. Bloating, the inability to belch with a distended abdomen, is the wrap working as a one-way valve that won't let swallowed air back up. And telescoping is the junction sliding up through a wrap that's still intact, which again gives you both reflux and dysphagia. For any of these, the first test is a barium swallow, not a scope, and the reason is specific. Barium shows you the shape of the wrap and where the junction sits relative to it, which endoscopy pictures can't reconstruct. The scope comes after, to look at the lining. Reflux from a slipped wrap gets the PPI back, and the tight wrap gets dilated. Dysphagia after bariatric surgery splits by which operation they had. A sleeve gastrectomy staples the stomach into a narrow tube along its long edge, and the weak point is the notch partway down called the incisura, where a kink, a twist, or a scarred staple line makes a fixed blockage with worsening trouble swallowing and food intolerance. The sleeve also tends to cause or worsen reflux rather than fix it, and it's worth understanding why, because it's a favorite point. The smaller stomach holds pressure higher, and the operation flattens the natural angle at the top of the stomach and disrupts the muscle fibers that help keep the junction closed so acid gets driven up. That's exactly why a sleeve is generally avoided in a very obese patient who already has reflux, and the gastric bypass is the reflux-friendly bariatric operation for that person. The bypass, in turn, causes dysphagia mainly by scarring down the new connection between stomach and small bowel, showing up weeks to months out with worsening trouble with solids, and the treatment is balloon dilation through the scope, often more than once. And an ulcer at that same connection causes upper abdominal pain, dysphagia, and bleeding, with the risk factors being smoking, which is the biggest one you can change, NSAIDs, and H. pylori, treated with high-dose PPI and fixing those factors, with surgery only for ulcers that won't heal or that perforate. Now the systemic diseases, starting with scleroderma, which has the most recognizable manometry pattern because it hits two things at once. Fibrosis replaces and weakens the smooth muscle of the lower two-thirds of the esophagus, where the smooth muscle lives, while sparing the striated upper third, and the same process drops the resting pressure of the lower sphincter. So the pump quits and the anti-reflux barrier opens at the same time, which is the worst possible combination. Acid pours back with nothing holding it out and no wave to sweep it away. What follows is severe erosive esophagitis, peptic strictures, and Barrett in somewhere around 5 to 35%. The manometry, covered fully in Chapter 2, is failed contractions on essentially every swallow together with a weak lower sphincter, and that pairing is what separates it from achalasia, where the sphincter instead fails to relax and the relaxation pressure is high. Treatment is aggressive twice-daily PPI, raising the head of the bed at night, and dilation when a stricture forms. And the operation you avoid is a fundoplication, because a wrap needs a working pump to push food past it, and here the pump has already failed, so the reflux may look like the main problem, but wrapping this esophagus just trades it for obstruction. Sjogren causes dysphagia in a completely different way, by drying up the saliva that swallowing depends on, rather than by damaging the esophagus at all. The autoimmune attack on the salivary and tear glands takes away the lubrication and the moisture that forms a swallowable bolus, so patients struggle to get a swallow, started with dry foods like bread or crackers, do better with sips of water, and are worse by the end of the day. Treatment is stimulating saliva with pilocarpine at 5 mg 4 times a day, or sevamaline at 30 mg 3 times a day, plus saliva substitutes and good oral care. Sjogren is also a reason reflux can seem refractory when the two coexist, because saliva normally helps clear acid from the esophagus, so losing it makes the same amount of acid feel worse. Amyloid causes dysphagia by depositing stiff protein fibrils into the muscle of the esophageal wall. The two adult forms to know are AL, the light chain type from a plasma cell disorder, and ATTR, the transthyretin type, either inherited or the wild type of older age. The bedside clue is a big tongue, macroglossia, which points toward AL and should send you after serum and urine immunofixation, free light chains, and a marrow biopsy when the picture fits. The manometry is variable because it depends on where in the muscle the fibrils landed. In treatment goes after the underlying process, chemotherapy, or a stem cell transplant for AL, and drugs like tafamidis, patisiran, or inotersen for ATTR. The esophagus itself isn't the target. The nerve and muscle diseases hit the throat phase of swallowing, and you recognize them from the rest of the exam. ALS degenerates the motor neurons that run the bulbar muscles, so the throat dysphagia comes with fasciculations, a wasting tongue, and progressive limb weakness, and the nerve study confirms the denervation. Myasthenia gravis is an antibody attack on the receptor at the nerve muscle junction, and its signature is fatigue that gets worse across a meal and better with rest, often with droopy eyelids and double vision, with the acetylcholine receptor antibody positive in most, and the MuSK antibody catching some of the rest. Treatment is pyridostigmine, plus immune suppression and sometimes thymectomy. Polymyositis and dermatomyositis are inflammatory muscle diseases with symmetric weakness of the proximal muscles, a high creatine kinase, and throat dysphagia in about half when the bulbar muscles are involved. And dermatomyositis adds the skin findings, the heliotrope rash on the eyelids, Gottron papules over the knuckles, the shawl sign across the upper back, along with a raised cancer risk that means age-appropriate cancer screening, with gastric, lung, ovarian, breast, and lymphoma at the top of the list. Radiation injury comes in 2 phases. Early on, during or just after chest or head and neck radiation, there's mucositis, with severe painful swallowing, dysphagia, and dehydration, managed supportively with topical anesthetics, pain control, and nutrition. Later, months to years out, a fibrotic stricture forms in the radiation field, with worsening trouble swallowing solids, and swallow therapy during and after treatment lowers that long-term stricture rate, while established strictures get endoscopic dilation, often repeated. A completely blocked segment can require the technique of coming at it from both ends at once, above and below, to reopen it. So the theme is the same all the way through. The diagnosis is in the history the scope report doesn't carry. The post-surgical ones you recognize from the operation, and you look first at a barium swallow that shows the anatomy rather than at a scope. The systemic ones you recognize from the disease outside the gut, and the scleroderma pattern, failed contractions plus a weak lower sphincter, is the one to carry into the next chapter. Because that pattern is where Chapter 2 begins. It covers esophageal motility under the current classification, which checks the sphincter's outflow first and the body's squeeze second, and which separates the 3 types of achalasia that each point to a specific treatment. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of Chapter 1, and I'll see you in the next one.